LASIK is considered to be an almost safe surgery to get rid of the glasses, but we all know that any surgery has its own complications. So, in this video, we're going to talk about two of these complications, the flap slip and the flap striae. Starting with the flap slip, we will present a case scenario. A patient with -7 diopters refraction and no history of wearing glasses or contact lenses was presented to us. He lived 150 kilometers from the LASIK center and used public transport. 2 days past LASIK procedure, the patient came complaining and said, "I have something like a fish scale in my eye. I was going to pull it out, but I thought I'd better ask you first." And by examination, a slit flap was found. This flap was everted with removal of the epithelium and debris, stretched again in position, and sutured. The flap slipped again and was resutured for the second and third times, as we have light repositioning challenges as epithelial ingrowth, infection, fixed folds, and contracture of the flap. The flap slipped again and was excised, but the patient didn't come back. And to understand the etiology of the flap slip, we have to take care that the LASIK flap adherence depends mainly on capillary attraction of the tissues. So, hydration of the flap and applying surgical trauma together with prolonged surgical time can hinder the LASIK flap adherence and predispose to flap slip.
وكما قال ابن النفيس في كتابه المهذب في الكحل المجرب عن تفرق الاتصال في جروح القرنية، وأما تفرق الاتصال في الجراحة فلضعف العضو عن جودة تدبير غذائه ومن مقاومة الدفاع ما يدفع الفضول إليه، وهذا الضعف سببه الجراحة وما يحدث عنها من سوء المزاج.
Other factors predisposing to flap slip include wide and thin flap with small and nasal hinge. Post-operative predisposing factors include the presence of a dry surface and friction of the flap on the bed while rubbing the globe. And to prevent the LASIK flap slip, the surgical time must be limited. Spreading the flap and drying the gutter are also needed. Adding to this, at the end of the surgery you have to wait, do the blind test and the Striae test by applying gentle pressure next to the limbus and observe for the Striae development to make sure that the flap is well coapted within the bed. Post-operative examination is needed 20 minutes after the surgery and on the next day. Tell the patient to go home and sleep with no rubbing and no drops for this night. Moving to the next complication, we will talk about the flap striae, which are defined as small folds in the cornea as a result of LASIK surgery. They are further classified into microstriae and macrostriae. Microstriae are microscopic superficial folds involving the Bowman's layer. They are visually insignificant and require no surgical intervention. Macrostriae are larger for thickness folds in the cornea that are visually significant and often require surgical intervention. It is believed that the mismatch in the curvature between the flap and the newly altered stromal bed is the main reason for the striae, as the altered central convexity of the stroma can lead to flap redundancy that is difficult to completely flatten, which has been referred to as the tenting effect. Risk factors for striae development include high myopia as a preoperative factor. Operative risk factors include thin flaps, poor alignment after flap placement, improper insertion of the bandaged contact lens, and improper removal of the eyelid speculum. Long ablations also have a higher risk of developing significant striae due to the dehydration effect. Post-operative risk factors include diffuse lamellar keratitis due to microscopic scarring and rubbing of the globe. Striae are best viewed either by retroillumination through a dilated pupil or by looking for negative staining with fluorescein at the apices of the striae and pooling in the troughs. For striae noted in the early post-operative period, the best management is to lift and hydrate the flap with hypotonic salt solution that causes the tissues to swell with better coaptation of the flap. But folds not responding to hydration will need more aggressive intervention by debriding the epithelium overlying the striae. But what if the striae were detected lately? Can any measure repair what the time did and stretch the deep folds? The previously mentioned measures, including flap hydration and removal of the surface epithelium, are not of great value in long-standing striae. Even powerful stretching might not be of great benefit, and the results are not promising. Other measures to repair long-standing striae include flap suturing, which decreases the visual acuity, ironing to relax the collagen fibers, and transepithelial phototherapeutic keratectomy to remove the peaks of the striae without touching the troughs. So, in conclusion, proper preoperative evaluation and intraoperative management can minimize the incidence of post-operative LASIK flap striae and prevent flap slip. When these problems do occur post-operatively, the surgeon must initiate the treatment as early as possible. Thanks a lot for listening.